Good evening and welcome to this dermatology presentation. This is Hannes Gebauer. I'm one of the principals of Fremantle Dermatology, and the topic I've been asked to speak on is common diseases and management in dermatology. Now, as usual, this is going to be a sort of a slide presentation. I'm going to highlight common conditions and talk about diagnostic criteria, clinical signs, and things that I think might be helpful to you in rural practice. So the first slide is of a foot, obviously, scaly rash. It's diffuse, and you'll notice it does extend up onto the toes, pretty much all the toes, mostly on the forefoot. So the question is, what could this be? Now, clearly, you'd be thinking, is it tinea? Is it dermatitis? Is it psoriasis? So they're the three main things to think of. Now, tinea will often be unilateral. So if it's on one foot and not the other, and there's no involvement on the palms of the hands or the fingers, then really you're thinking tinea. Usually tinea itches. So if it's itchy and unilateral, the odds go up. Always do a scraping test, whatever you think, because you can be fooled, and there could be dual pathology. It could be psoriasis and tinea, or eczema and tinea. The second thing is that if it's bilateral and symmetrical, it's more likely to be psoriasis and tinea. So again, do your scrapings, but these are things that would point you to a certain direction. Now, dermatitis could be endogenous or it could be exogenous. So the question is, could it be an allergy to footwear? Does the person have a contact dermatitis to the soles of their shoes or the rubber boots? And clearly, if it's a foot dermatitis, it needs to be bilateral, needs to be symmetrical, and it needs to be very itchy. Psoriasis invariably, generally doesn't itch. So moving on to another slide, second slide here, this is of course a foot, hyperkeratotic, crust eruption. It is symmetrical, absolutely the same on the left as it is the right, and this patient has psoriasis. So when you come to treat this person, there are a number of treatment options, but topical steroid ointments. It's dry, so you need an ointment. Something like the combination treatments of Davabet, which you're familiar with. You may not be familiar with Enstellar foam spray, which is made by the same company as Davabet, same ingredients. It has a steroid, full-strength steroid, and also a vitamin D analog. In combination, and Enstellar foam spray is pretty handy for this sort of thing. It's not as greasy, it's easier to use in the daytime. I'm a fan of it, works well, twice a day. It's on the PBS, and there is a streamline authority for it. Now, talking about groins here, how often do we see groin rashes? Pretty much all the time. So this is clearly a clinical sign of tinea. When you look at this, you can see there is this geographical margin. There are lines within lines. There are occasional little pustules, and the patient would generally be quite itchy. So somebody comes in, itchy rash, with this geographic shoreline sort of appearance, it's going to be tinea most likely. Hardly any point treating this topically alone. You need systemic therapy. This will be a dermatophyte, a true tinea, so therefore terbinafine would be your best option orally, 250 milligrams a day. I'd treat for minimum 30 days, sometimes 42. Sometimes griseofulvin, if they're price conscious, griseofulvin will do the job but take a bit longer. Now in males, pretty much tinea usually starts on the left-hand side. So if somebody comes in and got a scaly rash on the left-hand side, they're male. 90% of the time it'll start on the left. And it's to do with the left testicle hanging lower than the right testicle. The descent of the gubernaculum, from memory tells me that's what it used to be. So looking onto this one here, different story. This particular rash is quite uniform, it's quite diffuse, it has a well demarcated border, and it goes right up into the vault of the groin. So we're thinking psoriasis, we're thinking seborrheic dermatitis, but it would be a bad case of sebderm. We could be thinking of a contact medicament, are they allergic to what they're rubbing in their groin? That's what you'd be thinking. But you still got to think of tinea. Now, tinea would be incredibly itchy. If this patient is burning or irritating, definitely you'd be thinking psoriasis. So how would you manage that? Cool compresses, Condy's crystal soak, something like that. Calamine lotion even is quite cooling and will dampen this down. And then you'd use a cream, some form of steroid cream. You could use something potent for a short time, Elifrat cream for maybe 5 days, and then you'd cut back to hydrocortisone. So that's the sort of thing you'd be doing. You could use Elidel when it sort of quietens down a bit, but it might sting at this stage. So looking at this, obviously a child, you look at the groin region, you'd be thinking this could be a nappy dermatitis, the typical irritant type situation. But when you look higher up, you get this annular sort of lesion emanating from the umbilicus and a couple of other psoriasiform patches on the torso. So what I'm trying to highlight here is that flexural rashes in babies may not just be nappy dermatitis. It could be psoriasis or sebderm, and this patient indeed has psoriasis. And they wouldn't be itchy, they wouldn't be upset, they'd hardly be symptomatic at all apart from appearance. And extemporaneous tar creams can be really helpful here. I'd be using 6% LPC mixed in 10% glycerol in sorbolene 2 or 3 times a day. Works very well, often better than steroids, but if you need a steroid, Advanton ointment would be my choice. Now, solitary lesions on the shins. This guy here is country folk, comes in, he's got this annular plaque there, it's been there for a week and a half, and it's quite itchy. So, generally speaking, clearly you'd be thinking dermatophyte, but the majority of these turn out to be discoid eczema. So, just be wary that things that look like tinea may not be tinea. This is even, it's round, it's vesicular, it's crusty, there's no infection there. So this is a vesicular annular dermatitis. Discoid eczema is by far the commonest. Now, if you took scrapings from here, even if it was tinea, you're not going to get a result. When it's such an inflammatory lesion, even in the case of a true dermatophyte, you're going to get a negative result. So I wouldn't rely on your scraping tests. The best way to treat this is to treat it with a potent topical corticosteroid, Elifrat cream or diprazone cream. Whack it on every hour or so. It'll reduce the redness and inflammation. And if it's discoid eczema, it'll largely clear in about a week. If it's a tinea, the inflammation will settle down and it'll become far more obvious that it's tinea. If you start seeing pustules, then you'll say, it's a dermatophyte, set off an eczematous reaction. And there's no harm putting a steroid on tinea when it's on the extremities. This patient's got annular, crusty lesions on the torso, relatively asymptomatic. Clearly you'd be thinking, is this psoriasis? Is this something weird? What's going on? Well, clearly, this is psoriasis. You can see individual psoriatic patches anteriorly near the periumbilical area. It's asymptomatic. It's got a well demarcated border. You can palpate it. So, if you palpate it, you can feel it quite thicken. There are no follicles. There's no folliculitis or anything like that. And tar creams would be very helpful here. You'd use, my same formula, 6% LPC and sorbolene, and combine that maybe with some Elifrat cream at night. This is a different patient, and again, you'll see the pattern is completely different. You've got this marching effect where you've got a geographical border, you've got borders inside borders, an area of sparing, and this is the classical trichophyte rubrum that you'll commonly see in the country. And it's often been there for year after year after year, a little bit itchy, not terribly so. Patient needs to have scrapings here, needs to use an antifungal treatment systemically. And this is a close-up of the same patient. If you look carefully, you will see some folliculitis there at the expanding margins, and it's not a sort of a diffuse sort of well-demarcated lesion. Now, when you look at this sort of thing, you think, God, gee, this has to be a tinea for sure. Well, in fact, these lesions have been scraped time and time again, never found a dermatophyte. It's not particularly itchy, it just sits there, and it comes and goes, and the progress of this condition goes on for decades often. So this is erythema annulare centrificum. Scraping's negative. It does respond to steroid creams, but not as quickly as eczema or psoriasis would. So the long history, the asymptomatic nature of this usually is a giveaway. And it's thought to be a hypersensitivity reaction to something. It was originally linked to Candida, and this is one of the few things that has been proven to be triggered by Candida and other fungal things. It can be triggered by blue vein cheese and, a variety of other things. So unusual, rare, once seen, never forgotten. Now, you see a lot of this sort of stuff, a vague periorbital rash. And, of course, this day and age, everyone's got steroid creams in their cupboard, and they've got itchy rash. They put it on, goes away. Then, obviously, when they stop, they get a bit of a follicular perioral periorbital dermatitis pattern, which we normally treat with tetracyclines. But I just put this up here just to remind you that it's not always what it looks to be. This is unilateral. You can't tell from this photograph. But if it's unilateral and relatively diffuse, think of tinea again. So if it hasn't responded to topical steroids, it's not responding to your tetracyclines, it's clearly not perioral or periorbital dermatitis, think tinea. And stop everything. Just don't let the patient put anything on, and then review them, and you may find that there's a very obvious dermatophyte sort of spreading edge to it. Do your scrapings and treat systemically. No point mucking around with creams here. This is extending into the eyebrow, areas where there are hair shafts, and some dermatophytes will grow down hair shafts, and you're just not going to succeed with topicals. So either griseofulvin or terbinafine are the choice. This kid clearly has a very obvious tinea. Again, it shows these margins, the outer margin and the inner margin. This is very characteristic of a dermatophyte like trichophyte mentagrophytes. Now, if it's a single lesion like this, topical terbinafine cream would be appropriate. You may not need to treat this child systemically. So terbinafine twice a day. It might take a month to clear. This is the sort of tinea that you'll get from a guinea pig. It's often trichophyte mentagrophytes, or microsporum will look a bit like this sometimes. So it's usually an animal-borne fungus. This is obvious psoriasis. Thin plaque, extensive. Another one here. Basically, the talks on common dermatoses, got to talk about psoriasis. So if I was in the country, I'd be using a full-strength steroid. I'd get an authority for Elifrat cream, 10 tubes, 5 repeats, and get them to apply that twice a day, liberally and to all areas. And I'd combine it with a tar cream. Again, 6% LBC, 10% glycerol in sorbolene. The other thing that's extremely helpful is UV. So if you're out in the bush and it's sunny, get outside in the sun. That'll make a big difference. Now, would I go further? Well, you could treat systemically, acitretin, not all that useful for thin plaque psoriasis. Methotrexate, brilliant, but not without side effects. Cyclosporin, brilliant, not without side effects. So really, topical therapies, used diligently will usually clear this, even though it's quite extensive. Now, this is another ballpark thing. Now, I mentioned soles of feet. You've got to think eczema or dermatitis. You've got to think tinea. You've got to think psoriasis. So this is pustular psoriasis. Once seen, they all look like this. When it's eruptive, it'll be very pustular. Now, the ideal treatment here is acitretin, but obviously that's by specialist prescription. But obviously, you work with specialists, ring them up, ask them to give you a script or send you some. Can be done. It's not a problem. So if I get requests from country people, I'll say, yeah, send us a photo. That's good for me. I'll send you a script for the patient. Now, however, there are simple things you can do. Minocycline, 100 milligrams BD is very effective. It's tetracyclines inhibit polymorph migration, and these yellow crusty pustules are just that, pustular lesions. So the pustulation will stop if you put them on minocycline. If that's not enough, add in colchicine in the highest dose you can tolerate, and you can do just very fine in a country region without acitretin. But if they came to a dermatologist, that's what we would do. Acitretin, initially 25 milligrams a day for a normal adult, BD if it doesn't improve. And that's the patient's hands. You can see the pustulation and that. But clearly, a lot of doctors look at this and say, oh, that's all infection. Well, it's not. And if you find staph there by chance, it's a secondary thing. So this is pustular psoriasis, symmetrical. Now, this patient was referred into the dermatology clinic at Royal Perth some years back. Basically, if you look very carefully, you'll identify that this patient has a simian crease. and a short thumb, and basically, has Down syndrome. So I had this rash, treated for psoriasis for many years, symmetrical rash, similar rashes on the feet. So I just throw this in to remind you about crusted Norwegian scabies. This is the normal standard scabies. That's what it does to patients who've had it for a long time. And if they have poor intellect and unable to communicate, or a low itch threshold, it may go unnoticed. And the way you find out normally with this thing is by starting to itch yourself. When you see patients like this, and at night time you start itching and thinking, oh, gee, I've got scabies, who did I miss? That's often how the penny drops. So just think about scabies as an alternative when patients haven't responded. And the reason I was referred to the dermatology clinic was that topical steroids didn't make any difference. Antifungals made no difference. So nothing's worked. Think scabies. Now, widespread thick plaque psoriasis. This patient has a serious problem. We're not going to win with creams and ointments. Even phototherapy with thick plaque psoriasis like this is not going to be the answer. So methotrexate would be the drug of choice, and that's what I would treat this patient with. Acitretin can be helpful. Cyclosporin is also not too bad. So methotrexate, acitretin, and cyclosporin would be the order, but certainly biologicals would be quite appropriate here. So if you've got patients like that, send them to dermatologists with a view to starting one of these biological agents. They need a PASI score of 22. This one would pass. Now, there are certain colleagues of ours who are, have a strong interest in biologicals. I guess all dermatologists use them. But in our practice, my brother Kurt is the whiz. We concentrate our knowledge through Kurt. Other practices, I'm not trying to say you probably send patients elsewhere, but Jonathan Chan in Burragoon is also pretty keen on biologicals. Ernest Tan in Vic Park. They're probably my three colleagues who I believe would be the most knowledgeable in this area. So, I would tend to send them off to one of those three people. Now, I've thrown this in just to remind you about medication. I mean, this guy clearly has a florid eczematous rash on his face, or psoriatic rash on his face. Take his shirt off and you can see there's a distinct collar line and, cut-off point on his forearm. So, this is a drug-induced photosensitivity. I mean, thiazide diuretics are probably the most notorious. This guy was on basically on moduretic. But griseofulvin can do this, amiodarone, and other sulfur-based drugs sometimes can do this as well. So I think drugs, what could it be that's doing this? Now, a little pustular eruption on the palms of the hands. When people see this, they often think, oh, viral. Is this a pustular bacteria due to septicemia or some funny form of vasculitis? But, of course, you can see a biopsy has been taken there for completeness. But pustular lesions on the palm of the hand, amongst other things, you've got to think psoriasis. So when you turn the hand over, you can see these pustules around the proximal nail bed, but clearly the pitting there is the giveaway sign. Nail pitting, psoriatic pitting, pustular lesions, patients are well, they're not in any pain, and again, the usual treatments apply. Tetracyclines, colchicine, but acitretin preferably. And many a patient have had ingrown toenails ripped off by surgeons because they have this horrible necrotic pustular looking thing. But again, this is pustular psoriasis. There is a variant called acropustulosis of Halepo, which really basically is a non-painful, pustular eruption, usually around the nail bed of the big toe. Often patients are put on countless antibiotics and have toenails removed unnecessarily. And if you remove a toenail off somebody with this condition, you're making it worse because the Koebner phenomena will dictate that the problem will get a lot worse. So yeah, trauma and surgery is not a good idea in somebody with psoriasis. Other simple skin rashes, eczema, good old eczema. Now I'm showing you stock standard eczema here. The problem is this patient showers too long or spends too long in a bath. I'm not a fan of these bleach baths, really, quietly, so I know my colleagues sometimes recommend them, but I think they do more harm than good. So in this patient here, really, you need to keep them out of the bath or shower, quick 30-second showers, avoidance of soap, the usual measures, all that. But when you come to treat, use a steroid ointment, not cream. If you put cream on this, it'll sting. The preservatives in cream will really irritate this patient. So you want an ointment, something that's basically quite soothing. So Advantan ointment itself would be really appropriate here, or you could use Alufrat ointment. Now, this patient, on the other hand, has a sort of impetiginized, weepy, crusty sort of eczema. Now, you're not going to win with ointments because ointments won't stick to wet surfaces. So what you want to do here, this is ideal to be putting a steroid cream, Alufrat cream or something similar under wet dressings, and this will settle it quite nicely. If there is superficial infection, a systemic antibiotic is appropriate. So creams here under wet dressings, absolutely. So no, I wouldn't use ointments, and I'd avoid creams like Novasone or Elicon because they do sting on inflamed surfaces. Alufrat doesn't. That's quite appropriate. Now, this is more widespread discoid eczema. Again, the showering and bathing is important. You'd use a potent steroid ointment like Alufrat ointment or Elicon ointment or any of those. Novasone ointment would be fine to each individual lesion. And more is better, okay? Don't hold back. Get a bulk supply and just get the patient to keep applying it 2 or 3 times daily. Now, this is a photograph of the web space of a chronic hand dermatitis situation. So this is the classical irritant contact dermatitis. You can see vesicles extending down in the palms, but you see these painful sort of fissures here. And that's the same patient. That's a photograph of a thumb. Hard to tell in this from this angle, but that's the photograph of the thumb. Fissured, cracked, inflamed, weeping. And the plan here is you need to use ointments. You need to smother it with potent steroid ointments, Alufrat, Diprozone ointment, Elicon, Novasome, any of those would be fine. The key thing here, though, is shampooing. One of the biggest problems that's not identified that we see in patients referred on with persisting hand dermatitis is that no one tells the patient to wear gloves when they're shampooing their hair. So probably the number one cause of an irritant contact dermatitis, in my experience, is patients continuing to shampoo their hair whilst they've got a problem. Now, obviously, we're going to see a few more of these patients soon with all this hand washing with the COVID crisis. We haven't seen them yet, but I figure that those who are washing their hands the most are too paranoid to come to doctors anyway, so they're all sitting out there sort of scrubbing away. And I expect when the crisis dies down, we'll be seeing a lot of people with an irritant contact hand dermatitis. It's not unreasonable to treat with a short course of prednisolone. Now, if you're going with steroids, you need to treat for 3 weeks. One of the situations I see commonly is general practitioners generally treat eczema the same way as asthma and allergies, etc. Well, that doesn't work. You need to be on steroids for 3 weeks. If you cut short, it will just bounce back and you'll be back to square one within a week of stopping. So 25 milligrams a day for 7 to 10 days, then a half a tablet for a week, and then a quarter tablet for a week, and then stop. So no surprises here. This is a teenager with the usual itchy vesicular pamphlix that we see, or dyshidrotic dermatitis is the other name, and quite often in hot, sweaty sort of situations, often when there's a bit of stress and anxiousness. So cool compresses, steroid creams, but basically the most symptomatic thing is putting their hands in cold water or Condy's crystal soaks will stop the itch and dry out these vesicles. Now, this is a dry eczema called astiotic dermatitis. The French call it eczema craquelé because it looks like a cracked windscreen. And, hypothyroidism can cause this, and so can massive diuresis. If you've got somebody with peripheral edema, you've dried them out with latex, you'll often get this pattern. So what you want here is a low-potency steroid ointment, like Advantan ointment, applied extensively twice a day, and that will usually shift it. Obviously, when it settles, an emollient needs to be done. So this pattern is very common. You see this depigmentation, and you're going to be thinking, is this pityriasis versicolor, which is the fungus, or is it pityriasis alba, or is it some other process going on? The reality is, if the patient is prepubertal, then it's not pityriasis versicolor. You don't have malassezia furfur in your scalp pre-puberty. So if somebody comes along and they're under the age of 12, they've got white patches, straightforward eczema. Okay, so pityriasis alba, mild form of eczema, and they're showering too long or they're in a swimming pool too long, and that's really the cause. Now, if they come along and say, "Oh, I had a florid red rash, I was allergic to the plants and I was climbing through trees and picking mangoes or something," then yes, you'll get loss of pigmentation. But unless they've given you an example of an inflammatory condition that's preceded this depigmentation, it's going to be due to too much time in water. Now, this is a former Karatha patient of mine, crusty impetiginized lesions on the body, swabs taken, reveal staph countlessly. Antibiotics tend to improve it but not clear it. And something odd, topical steroids didn't help, oral steroids didn't clear it. So this patient has benign familial pemphigus, otherwise known as Hailey-Hailey disease. It's a autosomal dominant trait where there is a adhesion, a tonofilament problem, which causes epidermal keratinocytes to separate, forming these sort of weeping sores. So if something's odd, you need to do a biopsy. A simple biopsy from this, any pathologist will say, yep, that's what it is. It has a very acantholytic appearance that can't be mistaken for anything else. And it can be a difficult condition to treat. Now, steroid atrophy. I'm throwing this here, steroid atrophy on the face. We don't see it. It doesn't happen, and the reason it doesn't happen is because everyone in the community that treats patients for any reason, we're all very strict about steroids on the face, and we just don't see this very often. So good work out there. So, again, this is what happens when you use potent steroids over a long period of time. I think I haven't seen atrophy of the face in the last 15 years or so. But this we see a lot of, steroid atrophy in the groin. So beware when you're using any form of a steroid to groins or axilla. Even a fifth-strength steroid creams will do this in a short time. I've had patients that have developed this type of strio within 2 weeks of using, tricordone 0.02%. So be very wary of that. If you are going to use a potent steroid or a moderate-strength steroid, fine, but make sure you supervise the patient and stop it very quickly in a week or so. Hydrocortisone is a better bet. So no prize for this really. I mean, granuloma annulare, dermal lesion, asymptomatic, highly palpable, dorsum of the foot, dorsum of the hands, elbows and knees, right age group, and it's been there for a long time. So parents are often paranoid about ringworm, but clearly it's not fungal. There's no epidermal involvement, it's all dermal. And here's a closer photograph of that same lesion. It's quite palpable. And the best thing to do is absolutely nothing, because, I do spend time telling patients no treatment necessary. There's hardly any point giving them an ointment, a steroid ointment, because, it hardly works. And there'll be an expectation. They'll be knocking on your door in 2 months saying, "It's not working, doctor, give me something better." And really, if you use a potent steroid enough that's going to clear GA, you're going to find that they're going to get atrophy anyway. So, because it's going to take months and months and months. So there's nothing wrong with telling patients, look, this is what it is. It's going to go away. You don't need to treat it. Don't waste your time. You've got more important things to do. And putting corticosteroid injections into this is really, there's a huge risk involved, and the benefits are not that great. So, patient perfectly good one day, then within a day or two, starting to get these erosive, bullous, purulent-looking lesions, and stock standard bullous impetigo. And other family members may have a number of lesions themselves. So it's contagious. No price for really picking that, but clearly cold compresses, Condi soak, something like that, systemic antibiotic of your choice. Ceflexin or flucloxacillin would be quite appropriate, erythromycin even, so whatever your flavour is, but you need to be on a systemic antibiotic. This patient here, stock standard acne, clearly think Roaccutane. You can see he's had a problem for a long time. You can see there's scarring. You can see that there are comedones, dilated, infundibulum of hair follicles are pretty obvious. So really, send them off, get them on Roaccutane. If you need something in the interim, minocycline 100 milligrams BD is better than doxycycline because it's anti-inflammatory. And that's the same patient. Front on, do him a favour, get him on Roaccutane. Now, I just have to say that some of my colleagues, unfortunately, use low-dose Roaccutane. I don't see the value in that. The recommended dose is 0.5 milligram per kilogram per day. That's what you need to shrink sebaceous glands. So this low regime of 20 milligrams a day, for an extended period of time doesn't work. It clears their skin, but the minute that you stop, within months, it's all back again. So you're not actually doing the patient a service by treating them with low-dose Roaccutane. Pharmacologically, they need a minimum dose of 0.5 milligram per kilogram, so anyone up to 80 kilos needs 40 milligrams. Now, this patient doesn't look that much different to the original one that I showed you with pustules, but these are not pustules, these are more nodular. And this patient's incredibly itchy, and the patient has scabies. So always be on the lookout for scabies, but one important area to look for is the sole of the foot. If you get a pustular itchy rash on the sole of a foot in an infant or a young child, it is scabies. So this is classical scabies on the sole of the foot, and that is the same patient, just the sole of that foot of that patient. This is an entirely different patient. Again, not much rash on the body, you can't see that, but little pustules on the sole of the foot. Think scabies. And pathognomonic scabies, nodules on the penis, folliculitis type rashes in the groin, you got to think scabies. Nothing else will do that. Papules or nodules on the penis, got to be scabies. Now, indigenous health, I'm just showing this. We see a lot of this. This is lupus. Of course, in fair-skinned people, it would be red, keratotic, and it would be, scaly and crusty, and there'd be follicular scarring. In indigenous people, you have this dark sort of appearance. On the lip, it can be white. But basically, UV-induced areas, symmetrical, crusty, scaly, follicular plugging biopsy confirms lupus erythematosus. And lupus is at least 100 times more common in the indigenous community than it is in Caucasian whites. This is another patient, same issue, lupus, see the biopsy scars with the scarring, discoloration on her cheeks. Hair loss in young indigenous people in remote areas. Of course, we're always thinking iron deficiency being the commonest cause, but I just throw this up there to remind you that syphilis is still prevalent in certain communities. This young girl had syphilis, and you need to be mindful of those sorts of causes of hair loss. So don't just pass it off as alopecia areata or iron deficiency, and they can have multiple reasons. They might be iron deficient and have syphilis. Now, this patient has this white sort of, you can see, it almost looks like an epidermal sort of erosive thing, but quite itchy. It's not Candida, because Candida would be much more pustular and erythematous, and you could wipe Candida off with a bit of gauze. These lesions are quite fixed. So this is lichen planus of the penis. So something you should be aware of. A potent steroid cream here would work really well. Elufrac cream aggressively for a week or two, and then something less potent after that. And this is a different patient showing lichenoid papules around the wrists. Topical steroid ointment is helpful. Now, these lesions have often been passed off as insect bite, the old white-tipped spider bite. Now, there was a review done a few years back, and where they reviewed all the cases reported as white-tipped spider bite that were published in the literature. 90% could be explained by some other etiology like pyoderma gangrenosum. So this patient, in fact, has pyoderma gangrenosum, and I've had patients referred to me by surgeons who've removed lesions thinking there's some necrolytic sort of bacteria and put skin grafts on to find that they've broken down. So when you see lesions like this, if they're not painful, the patient hasn't got a fever, then think pyoderma gangrenosum, and the treatment is oral steroids. This patient made it easy because she had a symmetrical lesion on the other forearm, and if they've got a history of inflammatory bowel disease or rheumatoid arthritis, that makes the diagnosis a lot easier. This patient really I've thrown in because she had a myeloproliferative disorder, was on a immune suppressing drug, and developed a biopsy-confirmed erythema multiforme. Looked pretty good to everyone. That's my biopsy scar there. She had erosive lip lesions, not quite Stevens-Johnson, but she had lip lesions that were concerning. So it was thought it was the myeloproliferative immune suppressing drug that was causing this, and that was stopped. Unfortunately, she subsequently developed a fever, and within 3 or 4 days, she died. Now, autopsy showed that she had miliary TB. Now, I'm just throwing that in there because this is a patient I looked after back in 1986 as a dermatology registrar. I've never forgotten this story. Nowadays, with all these biological immune suppressing drugs, do not forget tuberculosis, do not forget chronic infections. There are more and more people now in the community using these immune modulating drugs, and we're going to see more of these types of events. So always think, EM, whatever, could this be an infection? It may not be the immune suppressing drug. So tragic, absolutely tragic. Another hospital patient here, came from had a suprapubic prostatectomy, obviously some years ago, because I don't do many of those now. But the problem there was the wound kept breaking down. And when we look here on the left thigh, you can see there are also vesicular bullous lesions there. And this patient had pemphigus, and the wound was just breaking down at the site. And when you look up here on the shoulder, you can see their old erosive sort of bullous lesions. So, and he demonstrated the Nikolsky sign. So the way you do that is you just pick a area of normal skin, press your thumb on it, and you rotate it. Now, of course, the patient hates it because it hurts, and they abuse you. But if you can peel off the epidermis, then you've got an adhesion problem. And, in this case, it was pemphigus foliaceus. However, with drug eruptions, if you have that same sign, if you have somebody's coming in a drug rash and you get a positive Nikolsky sign, beware, because it's the first sign of a toxic epidermal necrolysis, which has a significant mortality. So if patients are on sulfur drugs, they've got a reaction to something and they've got a Nikolsky sign, you're in trouble. This patient was also in trouble. So a rash had been there for quite some time. Not really looks urticarial, but it doesn't come and go. It's not particularly itchy. It's been fixed. It does seem to get better in the summer, a bit worse in the winter, and clearly needs a biopsy. Palpable rash. It's relatively fixed. Does wax and wane. We are thinking mycosis fungoides. And I must say, I saw a patient today exactly like this. Now, this is the patient at the time of the biopsy. This is the patient 12 months later. So really, you're out there in public, in the wider community. These presentations do occur. Making the right diagnosis is helpful. It doesn't necessarily improve the prognosis of the patient, but it is helpful to get the right diagnosis and be the doctor. So I just want to say that skin biopsies are important. Anything that you are not uncertain about, or not certain about, that's a fixed lesion that's been there for some time, a biopsy is appropriate. Now, I must also say that the histopathologists at PathWest are first class. I've had, association with Ben Wood and some of the other pathologists there, and they are second to none. Okay, their turnaround time may not be as quick, but the quality of their reports and their ability to get the right diagnosis is absolutely right up there. So certainly you're not disadvantaged in country regions. PathWest are right on the money for histology. So send them the work, do the biopsies. You'll find they will be very helpful. And that's obviously a distal shot. Now this is probably my last slide. I think I've spoken long enough. When you get issues, weird rashes like this is weird. It's not eczema, it's not psoriasis. It's come up out of the blue. Is it sun sensitive? Well, not really. The areas that are not in sunning, but you have to think, those sorts of things. I mean, I must say, looking at this photograph, I'd be thinking lupus, but there are other conditions. The patient has sort of erythematous plaques behind his ears. Now, not itchy. Not particularly annoying, it's there and it's persisting and it's not going away. But when you talk to him, he's not feeling all that well. He's got patches on his nose. He's got a bit of episcleritis. And in fact, he had a bit of joint pain as well. So And the key thing here was when we did the full blood picture, he had a high white cell count and a neutrophilia. So basically, this is Sweet syndrome, acute febrile neutrophilic dermatosis, and the treatment is to treat him with oral steroids. So it's an idiosyncratic reaction. I do apologise for not blocking out this guy's eyes and not hiding his identity, but the key thing is that the episcleritis thing there on the right side was another clue to the diagnosis, and the erythema on his nose. So I did have his permission to show you this slide. So short course of prednisolone, it all settled out beautifully. 40% of these patients do eventually have hematological disorders, so you do need to monitor them from time to time. And one-off outbreak is not important, but if patients have recurrent outbreaks of Sweet syndrome, you do need to look further. So, look, I think my time's up. I don't want to, take up too much of your time. Look, it was a pleasure to be asked to talk to you. I hope that you've gained some, hopefully, whether they're pearls or just good ideas or thoughts about how to manage your patients. Then I hope you did get something out of this. I elected not to have an interactive session, rather more a didactic sort of photo sort of slideshow, but I'm really open to talking to any one of you out there. So if you want to, speak to me or you want to field questions, happy to do so. My email is hannes@fremantledermatology.com.au. That's probably the easiest way to reach me, because if you got a clinical picture or something you want to show me, I will respond. Or you can, if you've got, you want to just ring me, you can. My work number is 94304488. But after hours, I do carry my mobile phone, 0418 944 700. I'm happy to share that with you. And after hours, I do not mind getting interrupted. It makes me feel like a real doctor. I can, if you've got a problem and you need some advice, I'm happy to steer you in the right direction. So thank you for sharing your time and pursuing a little bit of dermatology. All the best, and good luck with the rest of your seminars. Over and out.